My pleasure today to welcome you to a webinar with Dr. Héloïse Cardinal. So Héloïse is a transplant nephrologist who's trained at the University of Montreal and then at McGill University, where she completed a PhD in epidemiology. She's an independent researcher at the Centre de Recherche du CHUM since 2012. And in the past decade, her work has been focusing on the interaction between auto and alloimmunity and the characterization of biomarkers of rejection and delayed graft function. She's also now experimenting with artificial intelligence research when it comes to allocation. Héloïse is a CNTRP investigator who's been part of Project 3 since the beginning and is now a new member of Project 2. So I'm going to turn it over to you. Thank you for being with us today.
My pleasure. So today I'm going to present to you some of the work we actually did for Project 4. And what I want to share with you today is not only the results that we got doing this work, but mostly the process that we went through when we had a research question that we wanted to address. And as I know some of you are trainees, I think maybe our insights, our mistakes, the whole process that we went through could be useful to you in the future. So I know not everybody on this call is a transplant nephrologist or involved in kidney transplantation, so I'm going to give you some background information in terms of acute kidney graft rejection. So we know that acute kidney graft rejection occurs in approximately 15% of kidney transplant recipients. And for those who may be less familiar with what it looks like, here on the left-hand side, you can see a normal kidney. And what I would like you to notice is that here we have the glomeruli, but that the tubes, the tubules, are very well preserved in a normal kidney, and they are back to back, so they're very close together. And the small space between these tubules is called the interstitium. And so when you have rejection, what happens is that you have an inflammatory infiltrate of mononuclear cells. And here, for instance, on this upper part of the right-hand side, you can see an intense infiltrate of mononuclear cells, so usually T cells, that are in the interstitium. So the tubules are not so close together anymore because you have the infiltrate between them. And what you need also to call it a rejection is that the infiltrate actually goes in the tubule. So here you can see that the mononuclear cells are going through the tubular basement membrane in the tubule, and that's called tubulitis. And so when you have the infiltrate in the tubules and in the interstitium, we call it tubulointerstitial rejection, which is T-cell mediated. However, at times it also happens that the inflammatory infiltrates affect the graft small-sized arteries, and we call this endarteritis. And it is a hallmark of vascular rejection. So here you can see that the inflammatory cells are affecting the graft vessel, and it can touch only the intima, so the inner side of the artery, but sometimes it can also affect the whole wall of the artery. So here are images of cell-mediated rejection. Now, you probably know that there is also antibody-mediated rejection, but this is not going to be the focus of my talk today. So we classify rejection through the Banff classification system. So this is a scoring system. And here is the most recent version, although the first published version was in 1993. So there have been updates nearly every second year. And so this is the most recent one, but the T-cell mediated rejection look pretty similar to the older versions too. Most of the changes have been in antibody-mediated rejection classification. So basically, when we talk about tubulointerstitial rejection, here is in the Banff classification, Banff grade 1A and 1B. So this is when the inflammatory infiltrates only affects the tubulointerstitial space. When we talk about more severe grades of rejection that affect the graft small-sized arteries, we talk about vascular rejection. And here we have grade 2 A, B, and 3, and the difference is the severity. So the more you go, the higher the grade, the more severe the infiltrate in the wall of the artery, with grade 3 being transmural arteritis. And this classification score is very relevant. Why? Because it is associated with prognosis, as you can see on this slide here. So this is graft survival. And here you have control, so patients who did not have rejection in blue, and in green, patients who had borderline rejections, which I didn't even mention, but very low grades of rejection. And then you have you have the curves that show you what happens when you have grade 1A, grade 2A, grade 1B, and grade 2B and 3, which are pooled probably because they're less frequent, but which have a dismal prognosis in terms of survival in the long term. So the band classification is strongly associated with the prognosis in terms of graft survival. So how do you treat rejection? Well, there are some guidelines. So the most recent guidelines are quite outdated. They date from 2009. But basically, the guidelines suggest that the initial treatment of acute T-cell mediated rejection should be steroids. Now, what protocol, what dose, which frequency to give it is not really defined in the guidelines. And then the second recommendation is to use lymphocyte depleting agents or KT3 for acute cellular rejections which do not respond to corticosteroids and for recurrent acute cellular rejections. Again, there is no specific protocol which is described in the guidelines. So in the absence of comparisons between various protocols of steroids, of various protocols of thymoglobulin, for instance, here is a short slide showing you what we usually do. So normally we give solomidrol pulses, which in a dose of 3 to 5 milligrams per kilo per day for 3 to 5 days. Most physicians will also intensify baseline immunosuppression, which means that, for instance, we're going to aim at higher TAC trough levels or increase the dose of mycophenolate mofetil to the highest dose that is tolerated by the patient. And as a second-line agent, we will use thymoglobulin. Most of the time, we use it only in corticoresistant rejections. But some centers use it as a first-line therapy when there is vascular involvement, for instance, grade 2A and more, or in cases of grade 1B with fastly rising serum creatinine. However, the treatment of rejection has problems. For instance, when you use thymoglobulin and even when you increase maintenance in immunosuppression and you give high-dose steroids, you can increase the risk of infection, whether it be CMV, PCP, herpes. You probably also increase the risk of cancer, for instance, PTLD, and there are other side effects of thymoglobulin, such as serum thickness, cytopenia, infusion reactions, or rash. And recurrent rejection can occur in up to 20% of people 3 months after treatment. So there are unmet needs in the treatment of acute kidney graft rejection, and this is on two sides. First of all, there are needs in terms of efficacy, because just as I showed you in the previous slide, all these rejections were treated, and yet you saw that the higher the grade of rejection, the lower the graft survival. So long-term prognosis is affected by rejection. And so this may be because there is partial but not complete reversal in terms of graft function, which may be due to the fact that the initial injury was so severe, or maybe to the fact that there may be ongoing low-grade immunological injury that we're not really addressing. And we also know that after rejection, 5 to 10% of patients will develop donor-specific antibodies, and that in and of itself can lead to chronic antibody-mediated rejection or acute on chronic antibody-mediated rejection. So there is an unmet need in terms of efficacy, but there is also an unmet need in terms of safety because of the side effects of thymoglobulin and increased immunosuppression. So this is where one of the aims of Project 4 was to develop a trial of extracorporeal photophoresis for the treatment of acute kidney graft rejection. And so extracorporeal photophoresis, I'm not going to pretend I'm a specialist, and I will explain it to you the way I understand it. It's been used in the clinic mostly for graft versus host disease in bone marrow transplant recipients. It's also been used in the treatment of cutaneous T-cell lymphoma and in the treatment of rejection, so of solid organ transplant rejection. So there have been previous case reports and case series of ECP in the treatment of heart transplant rejection, kidney transplant rejection, mostly refractory vascular rejections, but these were only small series, so it's not a practice that is commonly used in everyday clinical care. So basically, how does it work? So you extract leukocytes from the patient's blood via an apheresis procedure, and you treat these leukocytes with methoxypsoralen, which is a photosensitizing agent. And then you expose these treated cells to UVA, so to UV rays, which activate the psoralen and induce apoptotic cell death in these leukocytes. You reinfuse these lymphocytes and leukocytes to the patients, to these apoptotic cells, and it is believed that this reinfusion will modulate antigen-presenting cells, dendritic cells, will change this cytokine pattern and will generate Tregs. And so this is the way extracorporeal photophoresis is usually performed. Now, within the CNTRP, one of the differences that we were proposing is that there is a new agent, which is called TH9402 Therapeutic technology, and this agent would replace methoxypsoralen as a photosensitizing agent, and its advantage would be that it selectively integrates active T cells better than methoxypsoralen would, which potentially would lead to better downregulation of active T cell clones and better generation of Tregs. So there is now an ongoing trial in bone marrow transplant recipients within the CNTRP with this technology. So the research question was whether a strategy that involves ECP performed better than current treatment for acute cell-mediated rejection in kidney transplant patients. And so in the initial CNTRP submission, the proposed design was a one-arm phase 1 trial comprising patients with acute cell-mediated BAMF grade 1B and 2A rejections. So why was this population chosen initially? Well, it was because we wanted to have patients at intermediate probability of having an adverse outcome. So if you remember the first slide I showed you, we didn't want to have patients who had like grade borderline or grade 1A rejections, because most of these patients are going to go well anyway, so maybe you're not going to be able to see an effect of your treatment. However, if you take only the worst patients, grade 2B and 3, well then maybe you're not going to be able to see an effect of your treatment because everybody's going to go wrong. So to be able to see an effect, we chose this population who would be at intermediate risk of having the adverse outcome. So we thought of having, first transplants only, kidney only, not hypersensitized, and who have been off dialysis for at least 1 week post-transplant. And the intervention that we had proposed was solenoidal pulses, which is, as I told you previously, the usual treatment, first-line treatment for rejection, and the ECP protocol. And our outcomes were, of course, response to therapy and side effects, such as infections, neoplasia, or other side effects up to 2 years after the protocol. And so we first discussed this plan at a CST research group meeting in the fall of 2013, and also at the CNTRP annual meeting in 2014. And a few issues came up on which we felt we needed more information before proceeding. So we wanted to measure response to therapy, but how should response to treatment be defined? So was there an existing standard definition of the response to the treatment of rejection? Because it could be a few things. So for instance, you could expect that there would be functional criteria. So serum creatinine, which would go back to normal, which would go back to below the creatinine on the day of rejection. For instance, these could be criteria. Histological criteria. So what would you define as a complete response? Complete clearance of rejection. What about if the rejection is still there but lower grade? Would that be a response? So those were questions we were asking. Then use of second-line therapy. So in many studies before, the fact that a rejection would be steroid resistant was considered an outcome, but this was not really of interest to us, as we really wanted to have the full picture of when you use all the current treatment, what is your reversal rate. And graft survival, of course, which would be a great outcome, but we would need years to be able to show a difference over follow-up. So we didn't think we could wait for so many years to have an outcome. And then, what is the rate of response with current treatments? So there were little data on the response to treatment stratified according to the current Banff classifications when we looked at the literature. And one of our fears, too, was that maybe the rates that we observed in older literature would not be pertinent to the way we practice now. So, for instance, all the studies that were performed in the 1990s used less potent immunosuppression than after 2000. So it is possible that if you do develop rejection under strong immunosuppression, maintenance immunosuppression, then maybe your rejection is harder to reverse. We were also worried that in older studies, antibody-mediated rejection may have been misclassified as cell-mediated rejections, and why that is that we now know that when there is cell-mediated rejection that affect the arteries, so for instance 2A and above, there is frequent coexistence of antibody-mediated features, so for instance C4D deposition or microvascular injury in the glomerulitis or peritubular capillitis, for instance. So we really wanted to know what was the response rate in terms of reversal with current treatments for grade 1B and 2A in contemporaneous cohorts. Then we also needed that to eventually estimate an effect size to plan for sample size calculation for a larger trial. And we also needed that data to choose a study design for an eventual RCT. For instance, would we try to look at a superiority trial or a non-inferiority trial? And last, we needed to address some feasibility issues. So in terms of incidence of grade 1B and 2A rejections, so we needed to know what would be the anticipated timeline for the recruitment of patients, which would also have an impact on the number of centers we would need to have to perform the trial. And then in terms of acceptability of the trial, would physicians be willing to enroll their patients in the study we're proposing? And when we were at the CST meeting, we kind of had some worries because some centers said that they really wanted to use thymoglobulin as a first-line agent for grade 2A. And this was not compatible with our study design because we needed, we needed to have all our cells there. We didn't want to collect cells after receiving thymo. And there, in the protocol that we were proposing, there was also a delay in administering the steroid pulses for the treatment of rejection, again, because we wanted to collect the cells before administering the solomidrol. And this does entail that we have to wait for the biopsy results, do the cell collection, and then do the steroid pulses. So we were wondering if the physicians would feel safe with that kind of an approach. And so to try to answer some of these questions, the first thing that we did is that we went and did a systematic review of the literature. And mostly this review was aimed at seeing whether there was a uniformly accepted or frequently used, at least, definition of reversibility of rejection, and to try to see what was the reported reversibility rate with current treatments stratified according to the Banff classification system. And so this was a research question. What is the rate of response to treatment in pure cell-mediated Banff grade 1A and B, 2A, 2B, and grade 3 rejection episodes? So what we did is that a medical librarian performed a search strategy looking at these databases with the keywords kidney transplantation, graft rejection, therapy management, and Banff classification. We included only human studies of patients with acute cell-mediated rejection. The studies had to give information on the therapy that was received and the clinical response stratified according to the Banff classification, and we chose Banff classification 97 and over. And the reason for that was it is only since 97 that the Banff classification comprises elements distinguishing antibody-mediated and cell-mediated rejections. And that was important to us because we really want to address the question of pure cell-mediated rejections, because we felt that, we know that antibody-mediated rejections have worse outcomes, so we really want to have clean groups. And so what we did is that 2 investigators first reviewed the title and abstracts of the papers, and then there was a second round of selection assessing the main text, and then we began extraction in the very few studies that were actually giving the information that we needed. So you can see here the flowchart of the search strategy and the selection, and you can see that we did have many articles to start with, but after we went through eligibility criteria and looked at whether the articles were actually providing the information that we need, we just had 5 articles to review, which is very low and really speaks to a lack of data in this area. And so here are the studies. And so the first one that we found was from the 90s. And although they do say they use the 97 Banff classification, they did not make an effort to exclude features of antibody-mediated rejection. And here, if we look at the definition of response to treatment, what they did is that they took the percentage of fall in creatinine 14 days after treatment was started over the pre-transplant rise in serum creatinine between baseline and rejection, and they had a ratio of this. And if the ratio was over 70%, they called it a complete response, 30 to 70 partial, and resistance if it was less than 30%. And here, everybody got steroid pulses and an increase in TAC level, and not many patients also got OKT3, so less than 20% in both groups. And what we can see here is that they had a pretty good functional response rate, approximately 70% in grade 1B and grade 2A rejection. Now, the second study I'm not going to go through because it only dealt with steroid-resistant patients, and so that's a population who has more severe types of rejection, so I don't think it's giving an approximation of our study population that we can use. And next study was the work by Banusis, and they excluded patients with C4D, so features of ABMR, but up to 20% of their patients did have donor-specific antibodies. And here you can see that the definition of a response is very different from the one in the first study. So they called a complete response an improvement in creatinine at 1 or 6 months post-biopsy compared to creatinine at the time of the biopsy that showed the rejection. So it's probably easier to get a response here than there because the criteria are different. This study reported data on vascular rejection, whether alone or mixed with tubular interstitial rejection. And they had pretty good response rates, again, a functional response of 80% approximately. Now, this other study did exclude antibody antibody-mediated rejection, but I'm not going to go through it because they pooled grade 1A and B, and they pooled grade 2A, 2B, and 3. And I don't think that's a good idea because, as you saw on one of the first slides, the prognoses are very different, especially here. 2A, 2B, and 3 do not have the same prognosis in terms of long-term graft survival. So in this study by Haas, they did exclude patients who had DSA or C4D. So here we're probably really dealing with pure T-cell mediated rejection. And again, you can see that the response, the definition of what a response is very different. And so here they took the serum creatinine 1 month after the treatment of rejection. And if it came back within 125% of the pre-rejection value, so not the values at rejection, but the best pre-rejection values before, they call it a complete response. They also had a separate criteria at 1 month if the patient had DDF, because of course their patients were dialyzed, so they couldn't have like a baseline creatinine. And they also had one criteria, which was no rejection on a control biopsy performed within 20 days of treatment. So if you had one of these criteria, not the 3, but one, you were called a complete responder. And so in this paper, they report, the vascular rejections, grade 2A and 2B. 40% to 60% of these patients did have antibodies, so lymphocyte depleting agents. And you can see here that although we have, a pretty low rate of response in grade 2A with 52%, this is definitely much, much, much lower in grade 2Bs. And these two types of rejections should not be pulled when we're assessing the response to treatment. So as you could see from these studies, there was quite a wide variation in the definition of response. And so we tried to look if there had been consensus statement in the literature that proposed a definition for response to therapy. And so we found one, which was proposed consensus that serum creatinine, which would go back within 110% of the serum creatinine on the day of rejection diagnosis, and return to serum creatinine below the rejection creatinine by 5 days with maintenance to 30 days, that would be called a response. However, I have not seen studies which actually used this criteria to define the response. So one of the criteria that had been used previously, that's in the 90s, by the group, the work by Osama Gaber's team. They used the following response definition. So what they said is that if the serum creatinine 1 month after treatment, and they compared it to the baseline pre-rejection level. So if it came back within 125% of the best pre-rejection levels, they call it a complete response. Within 125 and 175% a partial, and more than 175% or graft loss, they called it resistance. And that definition has been used in at least partly in 2 of the 5 studies that we found in our systematic review of the literature. It has also been used in many studies in the 90s, but we did not include in our systematic review of the literature because they were not using the 97 Banff classification. And as a clinician, I must say that this definition speaks to me because we are comparing the creatinine 1 month after treatment to the best creatinine before rejection. And so to me, I like to see that my patient comes back to what he was before rejection to make a judgment on whether the rejection has gone or not. And so to summarize the reversibility figures that we obtained from this systematic review of the literature in terms of the study population we were interested in. So for the Banff 1B, we had 44% to 73% complete functional response. And of course, this wide variation is probably due to heterogeneity in the outcome metric that was used. And there was low use of lymphocyte-depleting agents in this patient population. So that was reassuring in terms of acceptability of the trial for transplant physicians across Canada. So, if they were worried that we couldn't use TIMO, well, we know that for grade 1B, there was generally low use in our systematic review of the literature. Now, for the BAMF2A, here, we had 52 to 80% complete functional response. Again, wide heterogeneity due to the variability in the outcome metric, but this time there was up to 30% use of lymphocyte-depleting agents. And there was no histological data in any of the papers that we reviewed. And I think this is really a lack of evidence that should be addressed. So what have we learned from this part of the work? Well, there was no standardized, uniform definition of treatment response, and I would say that that's really a lack because if we're going to test new therapies or if we want to compare studies, we have to use the same criteria to assess the reversibility of rejection. Now, we found no histological data to assess the reversibility of rejection, and this really calls for need for more data on this topic. And we observed a 45 to 80% complete functional response in BAMF grade 1B and 2A rejections. This was our population of interest. And so we can see that there could be some margin to study superiority because this is not like perfect response. And since we observed up to 40% use of thymoglobulin, at least in grade 2A, you'll see later in other studies that we performed that we also had quite a few 1Bs who had lymphocyte-depleting agents, we could also position it as a strategy that would spare thymoglobulin use. So because we had such little data on the histological clearance of rejection, and also because we wanted to assess feasibility in terms of the number of centers to recruit, we performed a retrospective cohort study. And there we wanted to assess the reversibility of the rejection episodes according to their current BAMF classification, and we wanted to see also whether the clinical or the functional response was associated with the histological response to treatment, because if clinical response is very, very good, well, maybe we don't need histological data that much. Well, actually, we really thought it wouldn't be that good, and you'll see the results. So we performed this retrospective cohort study at Maisonneuve-Rosemont, at the CHUM, consecutive kidney transplant patients between 2008 and 2013. We used the Gabor criteria as the functional clinical response because this was the one that had most frequently been used, and also as a clinician we felt that this was probably the most valuable response that we could use. In terms of histological response, we measured it on biopsies that were performed within 3 months of the rejection episode. And so we called a complete response when there was complete clearance of rejection on the control biopsy. And we called it partial if there was persistence of rejection, but of lesser grade than on the initial rejection biopsy. And so this is our cohort. We had 554 patients, and we did not include patients who had rejections on surveillance biopsy because we wanted to be able to calculate functional reversibility. So we really focused on those with clinical indications. And amongst these patients, we had approximately 100 with pure cell-mediated rejections and 25 with antibody-mediated or mixed rejection episodes. And among these 126 patients, 50 had control biopsies after their initial rejection. So here are the characteristics of the patients. And what we can see is that, patients with antibody-mediated rejections were younger, which is expected as they're more potent immunologically and sometimes take less of their medications. They were more likely to be to have high CPRAs before transplantation in class 2, and they were more likely to receive thymoglobulin as induction therapy. So in both our centers, we use basiliximab as the standard induction agent, but if the clinicians think that there is a higher risk of rejection, they can choose to use thymoglobulin. So probably these patients, the patients who did undergo ABMR, were perceived as higher risk by their physicians. And so here here is the functional response according to Banff grade. And so what you can see is that the functional response, as defined by the Gaber criteria, was pretty good in borderline 1A, 1B, and 2A rejections, approaching 80%. It was much lower in antibody-mediated rejection or mixed rejection, and in grade 2B and 3, although we had very few cases. So here is to take with a grain of salt. So as you remember, very, very high response for borderline 2As, but here we can see that there was significant use of thymoglobulin here in grade 2A, up to 50%, and even in grade 1B, up to 25 to 30% use of thymoglobulin. And I just mean to say that here in both our centers, this is used as second-line therapy, not as first-line. So this is when patients do not respond to corticosteroids. Now, when you look at the histological criteria, the response rate is much lower than the great functional response rate that we observed. So if we look, between borderline 1A, 1B, and 2A, you have complete clearance of rejections in biopsies that were performed in the 3 months following rejection that are around 35%. And another 30 to 35% still show rejection of lesser grade. Now, we can suppose that this may be an underestimation of the true rate because this is an observational study. So why did we rebiopsy these patients? We don't rebiopsy everybody. So maybe those were the ones that we felt were not doing as well, and this is why we biopsied them. But when we looked at the association between the clinical response and the histological response, what we could see is that, so these are all patients who got a biopsy here, are 51 patients, and what we could see is that when you do have a complete clinical response with the Gaber criteria, the positive predictive value of having complete clearance on your biopsy is very low. So complete functional clearance is defined as with the Gaber criteria is certainly not predictive of complete histological clearance, which does argue for rebiopsying patients and looking at their data. The negative predictive value is much better, so when you do not have a complete response, it's more likely that you do not have a complete histological response either. So if we summarize what we found in a retrospective cohort study in terms of reversibility, we had pretty good functional response rates, which are pretty similar to what I showed you in the systematic review of the literature. But now we have the histological response, which we did not have from the systematic review of the literature, and which was, between 30 and 35% complete histological response. And although this is obtained with 30 to 50% use of lymphocyte depleting agents. So from this retrospective cohort study, what did we learn? Well, we got a better assessment of the potential recruitment rate. So our two centers combined performed approximately 120 to 140 transplants per year, and we had 7 eligible patients per year in these two centers. So this is not such a common occurrence. Now, in terms of defining the response, we feel that we do need histological confirmation of clearance since there was poor predictive value of the functional response. The complete histological response was not very high, although for sure we can argue that this may be underestimated since this is an observational study. But with that, we could envision that ECP could be trialed as superior to standard treatment, maybe envision, because the response rate is not that high. And we observed a 30 to 50% use of thymoglobulins, which could also position ECP as a strategy to spare thymoglobulin and, avoiding its side effects such as infection and cancer. And so finally, the last piece of data I wanted to present to you was the survey that we performed. So because we need to compare ECP or any novel treatment modality to current clinical practices, we really felt that we needed to have an overview of what were those those practice patterns in our country. And this speaks to the feasibility and the acceptability of a potential trial and should also help us design what it will be the standard treatment in the control arm of a future randomized controlled trial. And so 3 transplant nephrologists, so that's Tom Blithansen, Lindsay Nical, and I, designed a survey. Questions were translated to French. Both versions were built into a web-based tool. This survey had 34 multiple choice questions divided in 6 categories, mostly related to the diagnosis and surveillance of TCMR, the treatment of clinical TCMR, of subclinical TCMR, and how we monitored the response to treatment. So this is the flowchart of survey and respondents. So what we did is that we used the CST mailing list and did a first blast email through them on June 2nd, 2016. We had a reminder 1 month after. Notice that this may not have been the best time of the year before the vacations. So if you do a survey, maybe try to do that at another time. The other thing was that there was a survey right before ours, so we didn't want to do 2 surveys at the same time to try to maximize the response rate. So that's another consideration to look at. If many surveys are coming in at the same time, you don't want that to happen. Because we wanted to increase the response rate, we also presented the project at the CST meeting in the October of 2016, which was followed by another blast email. And in the end, we had 47 respondents from 18 centers. There are 25 transplant centers in Canada. So we had, representatives from most centers, mostly transplant nephrologists, underrepresentation of pediatric specialists, unfortunately. I'm going to go, I see the time passing, so I'm just going to go a bit faster. Almost 25% to 28% of respondents reported that they did use surveillance biopsies. Now here, something that reassured us, a question that we asked, so, almost all respondents always or almost always awaited biopsy results to start the treatment for rejection. So that reassured us because, as you remember, I told you, we had to do the cell collection and wait for the biopsy results to run to actually recruit patients in the study. So that was reassuring to us. What was also reassuring to us is that for grade 1A and 1B, almost all respondents only used steroid pulses and no lymphocyte depleting agents, although some respondents, but not the majority, 9%, used grade 1B as a first-line therapy. So these are the most popular solumidrol pulses regimen that were used by the respondents. So, most of the respondents use IV steroids and not pearl steroids, but the way they gave it was pretty much half and half between, a total of 750 milligrams IV for 3 consecutive or 1.5 grams for 3 consecutive days. And most of the respondents had a steroid taper after the high-dose treatment, which, again, was split half and half between pretty short taper of 14 days or duration of 1 month and over taper. And so this helped us in designing the standard treatment in the control arm that we're eventually planning. And now, again, here, this was a question that we asked because we wanted to know if we could position ECP as a, thymo-sparing agent. And here we asked, how much value would you place on a new therapy that could be as effective as thymo, so non-inferior, but without increasing the risk of infection of cancer. And here you can see that most respondents either said it would be extremely valuable or very valuable. So I think, the idea is important, certainly. And here we also, in terms of feasibility, wanted to know if they would be willing to delay initiating IV pulses for 3 days, time to get the biopsy results and do the cell collections, and, majority said yes. So what we've learned from this piece was that there was actually pretty high value on the treatment that would be as effective as thymo with none of these associated side effects. So I would say that in future trials, a non-inferiority design would certainly be acceptable. This will help us to design the steroid protocol consistent with common practice in the control arm of a study we would like to do. And it was reassuring in terms of acceptability that there was very low use of thymo as first-line therapy. And so just to conclude, because I've gone over time, we are now developing a protocol with the support from the CNTRP and from TCL, and this will be a pilot trial of ECP with Theralux, the new agent I talked to you about for transplant patients with acute cell-mediated rejection. We're still defining the study population. I think we'll probably go for cell-mediated rejection 1B, or 1A and 2A, depending on how much safety data we need. This still needs to be discussed. We're still having calls about that in 10 minutes, for instance. And we will collect efficacy and safety data for 5 patients. This is a costly regimen, and so we'll have to see in the future how we will position it, because it's, if I am not misled, this is between $10,000 and $15,000 for the treatment. So this is not benign. So we really need to either, I think, position it as something that would spare thymoglobulin because it has a high perceived value from the clinicians, or if our first data indicates that some markers of B-cell activation are addressed by this therapy, this could actually eventually be tried in patients with antibody-mediated rejection. And I think that there, as we have really nothing that is proven very effective for ABMR, this is really something that could help us in the future if our first data suggests that markers of B-cell activation are improved with this therapy. And so I hope that you like the presentation and that our insights and the whole process will help you potentially if you do have to develop a research protocol. Thank you.